saturation picked up to. And
The pulmonary blood is bypassing the oxygenation, and
Now he has presented to the
They may be added on inhaled.
60-year-old chronic alcoholic male came to the emergency department with a 60-year-old
complete MRI brain protocol.
and exposure, distended, tense up, and
pressure support ventilation.
So good evening, doctors. We are happy to once again welcome to our 25th session of Impact PG. This session is so special to all of us because it is not just the culmination of education. It is the commitment about INEOs towards the medical fraternity. We are so glad that this session has been consistently been conducted on every Saturday by sharp 7 p.m. and goes on up to about 8 to 8:30. We really express our wholehearted, sincere gratitude to every PG doctors and our consultants, the examiners, the senior faculties who could contribute their valuable time in the interest of educating the students. Thank you very much once again. As you are all aware that this initiative had been one of the most important turnkey projects for us because there was always a gap and a platform for the students to get themselves constantly updated about various cases across the country. So this platform not only provided a meaningful way to connect with the examiners, but also it provided the adequate levels of confidence for the students before they appear for the examinations. So we are glad that 24 topics have been completed, and today we are stepping into the 25th topic. In this whole journey, I take this opportunity to thank Dr. Raman Muralidhar, Dr. Kiran Rajagopal, who have been right from beginning, been the backbone in guiding us through this entire journey, and we are able to reach up to the level of 25. I'm sure still it is only a beginning. When I gather, there are more than 400 students who pass out every year in DRMB critical care. We have more to do, more topics to discuss, and more students where we can give them the confidence. So we really look forward to continue this our journey for more number of weeks, and we look forward for each and every one of your contribution in this active dissemination of knowledge. So with this brief note, I take pleasure in inviting the panelists of the day, starting from Dr. Ajit Kumar Yeki. Thank you, Dr. Ajit, for sparing your valuable time, sir, in today's our 25th program. We are so extremely glad that you are able to join us. You have been the ICCM the member, and you have been a very active participant in terms of the academic programs always. Thank you once again, sir, for joining us in this 25th program. I also express my deepfelt gratitude Dr. Anirban Home Chaudhary, despite his busy schedules, particularly in the government sector, he is able to join us today. Thank you, Anirban C, for having spared your time and joining us today. I take this opportunity to also thank Dr. Justin Gopaldas for his valuable time and his availability in the interest of educating students. He is always available at any time. Whether it is workshop or whether it is program, he is a known friend of every critical care specialist. Thank you very much, Justin Ji, for having joined us for today's program. So with this brief note, I heartfully welcome each and every one of the participants for this Impact PG 25th program and request the chairpersons or moderators to start the session from here. Over to you, Dr. Kiran Rajagopal.
May I make a single statement? I think I'll probably welcome Dr. Muralidhar Kanchi our
Yes.
teacher stalwart who joined the session, probably the senior most teacher in the group. So welcome,
Yes.
sir. I think he's one of the
I'm
participants.
really sorry.
Very good
I'm in the
evening,
mobile.
Murli sir.
Welcome, Murli sir. We are extremely
Extremely
happy
happy.
to have
Good
you.
evening, good evening, and thank you for having me. Thank you so much.
Thank you, sir. Thank you very much.
Thank you so
Welcome,
much.
sir. Welcome.
Yeah, over to you, sir,
Okay.
Dr. Kiran.
So much of immense gratitude and thanks to Al News family for this opportunity for me as well as Kiran. And so the star-studded panel is ready. And good evening, everyone. And this is a special welcome to a special session from Impact PG. And this is Saturday night and month of football, and the world watches the stars like Messi's, Ronaldo's, Neymar's, and Mbappe. And here in this stage, we are going to watch our four fab critical care specialists joining me and my co-moderator, Dr. Kiran, to take part or tear apart the myths of surviving sepsis 2026 guideline. As you all are aware, the 2026 surviving sepsis guidelines have set the stage. We know that in our part of the world, the real challenge is not knowing the guidelines, but it's adapting them to our reality. Tonight, we are not just reviewing the manual. We are going off script. We have curated a dozen of untouched, complex areas of high pressure zones, which are the guidelines meet the clinical front line. Out of the 17 strong and 19 good practice evidences, it was very difficult to come on to this 12, one dozen. Our fabulous four will break through these challenges, and we will have to conclude with a definite look for the future of the trajectory of the surviving sepsis campaign. Let us kick off the discussion from here. Before that, here are some housekeeping etiquettes for you to follow. Please keep your microphones on mute and encourage you to keep your cameras on so that the faces will make the virtual space much more realistic. And please use the chat box for the share your questions and thoughts, and we will be addressing you as many as possible. Let us keep our interactions professional and collaborative. Over to you, Kiran, to initiate the first question, and which will be directed to, I think, Sunil Karand has not joined, and you can direct to Murli sir the first question.
Dr. Justin was saying something.
I'll
Yeah.
take it. That's okay. No problem. I don't know, Dr. Murli, if he's okay, no problem. Whichever.
Yeah.
Okay.
Yeah, carry on.
Okay. Thank you, Murli sir. And so we will be starting the today's session with the first question. I think I will, as Dr. Sunil is not here, I will give the question to Dr. Murli. So, sir, the 2026 surveying sepsis guidelines emphasize system-based care through pre-hospital sepsis screening, hospital-wide quality improvement programs, and core sepsis protocols. So, you know that even we in India don't have a pre-hospital protocol for pre-hospital protocols for this trauma. We are lacking that. An emergency medical response and appropriate emergency medical response is lacking for the trauma. And how feasible are these recommendations for sepsis in our country? And what should be an ideal Indian model for pre-hospital sepsis care? How should it look like?
Okay, I'll probably answer, and Dr. Muralidhar could refine the answer at the end, probably. Yeah, I think so. Obviously, at the end of the day, whenever we are going to do some new intervention, like in this case, pre-hospital sepsis care, we obviously want to figure out whether that is going to be beneficial or not, cost effective or not, whether there is any research already done or not. And so we take these other things into practice, because at the end of the day, each intervention has a cost to it. Then at the end of the day, the cost can be sometimes just the financial, sometimes manpower, sometimes emotional, and sometimes the exposure to more tests or antibiotics or interventions that are probably sometimes not necessary. And so at the end of the day, we have to take the constraints of the available resource and available guidelines, available research, and the practicality, or in terms of implementing it in a setup where we have EMTs or ambulance teams who are probably, let's say, not as trained to identify sepsis and even a trauma care, as it turns out, based on that trauma surveys that were noted in AIMS, where the trauma center had done some research over the last decade along with the George Institute, and they've realized that the initial trauma care by ambulances have been pretty poor, and I'm pretty sure it's probably the same with the sepsis too. When this is compared to the available evidence, which comes from obviously from Western literature, where the ambulances call where they are going, whom to pick him up, and then what could be the case, and there is constant communication either where the patient's side, or upon arrival communicating to the base, or where there is a triage center, and also being in communication with the hospital where they are going to go. So which means that there is multiple data points for most people, whether they are at site triage or on the way triage or just before arrival triage, that happens to these people, whether it is a trauma or strokes or coronary events, or in this case sepsis. And even amongst these, the sepsis was doing far less in terms of the quality wise, even in Western countries. And so they have done a lot of those interventions, and I remember doing this in Melbourne and some of these centers in Australia where we were there. One about post cardiac arrest cooling, and then trying to give antibiotics for patients whom deemed to be septic before they are picked up and brought to the hospital, and all these kind of pre-hospital interventions. We had this sort of first-hand understanding of it, and we realized that they haven't really led to any major improvement in whatever the quality indicators, even in probably pre-COVID, where this was all happening. And I don't think it has changed much. And I'm applying those probably less favorable interventions in Indian scenario probably is going to be a lot more resource intensive, and at times can more likely to lead for us to be spending more and more resource and energy, whereas it probably would be easier for them to be transported to the nearest hospital. And that's probably my understanding of pre-hospital sepsis care, where we are significantly behind, where our core sepsis in hospitals itself is not evolved to an extent where it can manage. So probably we are a little bit far away from it, and should we ever get to that place. Dr. Muralidhar Kanchi sir could probably give maybe a couple of words, because obviously he's connected with the teaching and has a big Narayana's ambulance service that probably reports there, his experience in an Indian setting.
Thank you. Thank you so much. I totally agree with your statements that the interventions should be beneficial and cost effective. And each of these interventions may have financial and other implications. Our ambulance services are, as you said, significantly behind. I do agree with that. And there's a lot of scope for improvement. And that's all I would like to add. Thank you so much for having me. Thank you.
Yeah, so basically, see how feasible are the recommendations. So obviously, I believe that all these recommendations are going to be feasible in India, logistically, even financially. It's a matter of time. It is just slowly, developing over a period of time. So pre-hospital sepsis care, at least for the time being, we can look at these kind of warning systems. The so-called news, and some of the studies have shown that the news too is one of the warning system which has got a very high sensitivity and specificity. See, these system can be utilized even in pre-hospital care for identification of sepsis. We know that early identification, early treatment is extremely important in septic shock. So it can be there. Maybe in the future, maybe we are also going to have AI integration in kind of whether it's a pre-hospital care, in-hospital care, that is going to have the future. And especially when it comes to the the code sepsis thing. I think that's a very interesting thing because we all teach people and we all learn that because every 1 hour delay. Many studies and many studies have shown that even Kumar et al. The studies have shown that after the onset of septic shock, every 1 hour delay you can have a 6 to 8 a person in a mortality is there for at least for the first 6 hours. So basically, when you have a code sepsis, that enhances the awareness of you call for a code trauma. We have so many codes are there for code trauma, code stroke. All these are there. When you talk about code sepsis, and I think that's a very interesting thing, and probably every hospital can implement its own way in the beginning. So at least that will increase awareness among the healthcare workers as well as public. How important is the early diagnosis and treatment is there. I think all these things are still possible, strongly possible, but obviously slowly, steadily, it is going to be implemented step by step in all other Indian settings as well.
Second question is Dr. Anirban. The
Yes.
guidelines have moved away from the sepsis 3 kit Q so far, and we are back to news or news 2, as Dr. Ajit has said, and Muse and SIRS for the screening. Among the lot, which one you recommend to our EMS, which seems to be weaker compared to that of West?
I would recommend News 2 as the routine screening tool for sepsis in Indian ED. Although I can also say that SIRS can be retained as a supplementary trigger where News 2 is not yet implemented or for some specific high-risk complaints. SKU so far is no longer the primary screen because it has been shown that a score of more than 2 does not have a good sensitivity, and it fails to identify a lot of sicker patients who later deteriorate in the ICU. On the contrary, a news of more than 5 is a good trigger to institute special care, particularly monitoring the patients more frequently, as opposed to 4 to 6 hourly monitoring that is advisable for a news score between 4 to 6. A more than 5 or more is more. And if it is more than 7, that has even greater sensitivity. So that is a trigger for the code sepsis. So because this news has been found to be a better correlating with the mortality as well as the need for ICU admission, therefore, I recommend News 2 as the routine screening tool. And there, although Q so far has a poor sensitivity and it fails to identify, but it was earlier, it has been used with some amount of success, but now we have data to support News 2 as superior to Q so far in a hospital mortality prediction in sepsis patients with better area under curve, markedly higher sensitivity, and therefore there has been a shift in various emergency care sepsis pathways towards News 2 based screening rather than QSOFA. So we also see that the routine triage parameters that are used in News 2, like the respiratory rate, SpO2, SBP, they can be easily embedded into the triage charts, and there is no requirement of extra laboratory support. And therefore, existing data, including Indian cohort, suggests that it performs well despite heterogeneity in case mix and resource constrained situations, which is the reality in most of the Indian EDs. Thank you.
Interestingly, they now mention SIRS criteria. SIRS also is one of the scorings which can be used in ER.
Dr. Anirban, you said about no lab parameters. None of them contains any lab parameters. Is there any scope for another score which contains, in this era of point of care laboratory techniques, can we?
I don't think that any score which has lab parameters will be successful.
Yeah, none of them had lab parameters. So is there any scope for research in this area so that we can coin one with the lab parameters in this point of care concept areas.
I think that will be a too much of high optimism, but I don't think practically it will be a feasible, particularly in the ED level. We have to stick to the track and trigger score, and this track and trigger scores includes the news, muse, news 2, etc. I think we should. That is the final answer.
I think most of these are adapted to where it can be implemented both for resource rich and resource limited settings, and hence they've removed the investigations as a logging thing.
Not only resource limited and resource united, it is also the question of the logistics and the use of those logistics. I may have the money to spend, but it may not be justifiable to spend that money for a period of half an hour or extra for that reason, because the balance between the time spent and the results obtained has to be justified.
Can you please move to the next slide? So, the 26 guidelines actually recommend actual body weight to calculate the initial 30 ml per kg. It was in the previous guidelines also, they used actual body weight if the BMI is less than 30. But in our scenario, in our emergency departments, actually weighing critical ill patients is often not feasible because we don't have that weighing beds and all, and taking the weight of a sick patient is not possible also otherwise. And we as an intensivist are more used to ideal body weight. So how should we adapt to this recommendation without risking under or over resuscitation?
So 30 appears a very magic number in critical care, especially in sepsis. And the 30 is the mils is about the fluid of initial resuscitation. And this 30 basically it is based on observation studies where the actual body weight was used. The studies are used, this 30 ml per kilogram body weight are the studies where the actual body weight was used. That is one thing. Yeah, so where the actual body weight is used. And here when you use, see, this is the sepsis guidelines say that you should give at least 30 mils per kilogram body weight. And the 30 ml is coming for another very important thing. Another thing is that there are 3 landmark trials. The ARISE, PROMISE, and PROCESS trials. These studies showed that prior to randomization, around 30 mils of kilogram body of fluid was used in those studies. They found that when they compared the usual care with the goal-directed care, they found that when used for 4 to 5 liters of fluid, when people are using 2 to 3 liters of fluid, the outcome is the same. That is the reason the magic number of 30 is coming from fluid resuscitation. Coming to the BMI, less than BMI you have to give 30 ml, and more than BMI mean you have to go for the ideal body weight plus you have to go for adjusted body weight, which is actually ideal body weight plus 0.4 into the real body weight minus the ideal body weight. So this is how this one is. This is to avoid over resuscitation of these patients. If the patient is around 150 kilogram, we cannot give that much kind of fluid to the patient. That is the reason this thing has come for the BMI. The differentiation has come. So in our setting, if you ask me, obviously we all know that nothing is a magic number in medicine. That is one thing. And obviously these kind of beds as of now it may not be there, but we know that even in India we have weighing machines are there. All of us are using it in our at home. Even at home we are for even weighing our even our luggage and all. We also do that. So I don't think it is going to be far away. These beds are going to have at least some digital weighing facilities that is going to be there, and maybe some sort of upgradation of the beds also can be done. And I don't think it is very difficult. But we all know that nothing is fixed to this 30 ml. This initial resuscitation, then you need to closely monitor the patient. Accordingly, you have to give more fluid or less fluids. And interestingly, when I was just going through the 2026 guideline, it has been shown that most of the data is about retrospective data about the 30 mils per kilogram body weight. Even those patients who had, they found that even those patients who had, end-stage renal disease and even patients who had a cardiac failure, even those patients, some of the patients, even those patients can develop sepsis. Obviously, they can develop sepsis. In those patients, even then they did not receive this 30 mils per kilogram body weight. Even then the mortality was found to be high. So that is the reason. Once sepsis is diagnosed, you may have to give fluid, but obviously as he said, we are depending on the fluid restoration of multimodal inputs and thoughts. It cannot be just based on one number or one methodology. That's what I want to convey you. So definitely this adaptation is going to be there. As I already mentioned, slowly, steadily is going to be there. Digital, at least monitoring facilities can be there even in the beds. It is going to come up in the coming years or coming months. And obviously the current beddings can be upgraded to that level. I don't think it's an impossible thing even in Indian settings.
Thank you. Next slide, please.
Dr. Jasmine, the 2026 Surviving Sepsis Guidelines suggest early vasopressor initiation in septic shock when hypotension persists during or after the fluid resuscitation. However, the ARISE fluids trial recently published and showed no benefit with the restricted fluid and early vasopressor strategy compared with a more fluid-forward strategy after initial resuscitation. How do you interpret this seemingly ambiguous statement or messages? And what's your take on this? ARISE fluid against SSC.
So at the end of the day, no single study should clearly decide unless there is such a big change in the shift in the paradigm. Should change one's practice or one's guidelines in a way. I think that's probably the wisdom that was given to me many years ago. And obviously, at the end of the day, that statement means that when I talk about ARISE fluids, it should not be taken as an isolation and should be matched against a guideline. And so, what we want to do is that from the time Shoemaker, who is probably pioneered the resuscitation in terms of goal-directed care at the beginning, to the reverse study, to a lot more comprehensive studies like ARISE, PROCESS, and PROMISE trials that was in Europe, Americas, and Australasia. And then recently Clovers and one more of this, so another one. All these trials, when you look at it, we realize that the resuscitation volume wasn't matched against any guidelines. So they were the ones which were basically have never informed the SCC guidelines to some extent in terms of the starting volume. So starting volume came from a U-shaped curve of a database. Whereas when you're asking me about how I go about it, so I want to use the guideline, but my practice is driven by more comprehensive evidence that is available at this point of time in terms of. So in this time, the Shoemakers, which were supranormal resuscitations, the initial resuscitation could be almost above 8 to 10 liters of fluid in some centers, some places. Like for rivers, it was 8 and more liters. And then when we came to ARISE and PROCESS and other trials, it was around probably about 5 to 6 liters. And then Clovers and other things, we are dropping below 5 liters and 4.5 liters now. And so despite that, we are still giving a lot more than 30 ml per kilo in the first 6 hours. And that's essentially the take-home message, essentially. So in that context, ARISE fluid now, where it is actually dropping closer to 30 ml per kilo. You understand? We are first 6 hours, it's not even 3 hours, first 6 hours, we are now coming to what is considered to be a guideline level research. And we are achieving it not because we are rationing it. We still are in denial, and then we still saying that we are trying to figure out a resource like norepinephrine early start as a way to cheat our way to blood pressure and somehow stop yourself from giving fluid, even though the message for the last 25 years is that the more fluid you give, it's harmful. And this is probably the take-home message for me, is that for consistently 25 years, we have continued to reduce the fluid and continue to prove that we could get away with a lot less fluid. And each time you give a little bit more, you know that your every liter has a mortality attached to it. So essentially, if most of the ARDS trials, if you see the 7-day positive cumulative fluid balance, every liter has a mortality attached to it. And so and this is one aspect of it. And so we are trying to figure out how we could get to the low fluid. And so the second stream is that if you see the Schumacher, they were using PA catheters, central lines, and like a lot of other gadgets. You come to rivers, central venous gases and other things, and then Proves, maybe a central line. By the time you come to arise fluid, we majority of the patients don't even have a central lines. And nowadays we are publishing saying that you can give NORAD without central line. And all these things we have to take them all in conjunction with the way that when you synthesize all this, rather than looking at just the fluid, and how we come to today arise fluid is like you can give peripherally some NORAD as early as possible, cheat your way, and try to see how low you can go. Because unlike old days, if you don't give fluid, you will die. What we realize is that we are unfortunately had to undo that by giving less, at times marginally lower than necessary, but that is better than giving marginally more. And that's how the conflicting messages aren't necessarily conflicting, but they are in a way concordant.
Because mainly the ER physicians and other general physicians, what they have a tendency to usually give more and more fluid bolus in the fear of starting a vasopressor. So instead of starting vasopressor, each time they will give more and more. So by the time we get the patient, then they will be already fluid overloaded. So we will go with our current strategy of early vasopressors along with concurrent vasopressors along with fluid.
No, actually, 2026 SSC guidelines have taken into note various studies, including the ARISE. Besides ARISE study, there has been a lot of studies and a lot of systematic reviews which have found that cumulative fluid balance is harmful. And that is why the time when ARISE was conducted, the impetus of this ROSE concept was not that strong. Now, as the ROSE concept has evolved and it has strengthened, and it is being realized more and more that any extra amount of extra fluid is likely to cause more harm than good. And based upon the newer evidences, meta-analysis, systematic reviews, I think it is a prudent decision of SSC guidelines to show that early vasopressor initiation in septic shock is a recommendation. And although we can say that guidelines provide the framework and only the bedside provides the answer, but in spite of that, I think that this is a good framework which SSC 26 guidelines have given. And it is the same as the 21 also.
So it cannot be taken as a practice-changing study, even though designed by ANSICS and more than 1,000 persons were randomized. So we cannot use it as a practice-changing. All of the panels agree for that. Great.
Next slide. Please. So again, the question is to Dr. Destin and Dr. Murali. Melissa. No.
So we have, yeah, you.
No.
Previous one. Previous one.
Previous one.
Oh, that's all. Yeah.
No, previous one. Yes.
Yeah. So yes. Yeah. So this is about. No, the next one. Next one. Yeah. So this is about the antibiotic recommendation within 1 hour. Okay. So we have basically 3 types of sepsis there basically. Now our colleagues can add actually. I did not. So basically one is definite sepsis. You are very sure based on clinical criteria, symptom, whatever clinical things, you are very sure there's sepsis. That's the definite sepsis. And one is a probable sepsis. That means you have a high index of suspicion. And third one is possible sepsis. Possible sepsis mean medium, moderate index of suspicion. So very high index is probable sepsis. So moderate suspicion is possible. The other one is probable. There is a high suspicion is there. So what the guideline is telling that if you have a shock, whether when the patient is having a shock, whether you have a definite sepsis, possible sepsis or even probable sepsis, you need to give the antibody within 1 hour. So shock is there mean whether definite sepsis, whether it's a probable sepsis, you have a high suspicion, and possible sepsis you have a moderate suspicion. In all these cases, you have to give antibody within 1 hour. And in those patients with when the patient is having a even without shock, those patients without shock, even with the definite sepsis and even with the probable sepsis, that means high index of suspicion, even then you have to give the antibody in 1 hour. But when you don't have a shock and when you have only a probable sepsis, the possible sepsis, that means medium suspicion is there, but there is no shock, then you can give the antibody within 3 hours. So what I mean to say that shock, whether it's a possible definite sepsis, probable sepsis, very high index of suspicion, possible sepsis, all three you have to give antibody within 1 hour. But when you don't have a shock, when you have a definite sepsis or probable sepsis, that means you have high index suspicion. Even then you have to give it 1 hour. But if you believe that there is no shock, it's only a possible sepsis, you have a medium suspicion, then probably you can for 1 hour. This is to avoid overuse and misuse of antibody, because when you make a guideline, there will be a tendency for the clinician that you try to err towards doing something to save the patient, but towards the patient's benefit, not to risk the patient. Are you able to hear? Sorry.
Yes.
Hello. Then do that. That's what it is. So the question is, could this subjective lead to antibiotic overuse in India? So probably not. I think that's a concern. People can overuse that. I think it's a concern. But I know there is a subjectivity in this. We cannot well define this. I mean, an invite comment from
No, I think that why this India tag is required in this question. The subjective classification, yes, it can lead to antibiotic overuse across the world. Yes. Yeah. But this possible, probable, definite 1 hour, half hour, 2 hours, they will involve a lot of subjective variations. And those variations, if we try to minimize, we will be able to reduce unnecessary use of antibiotics. Yes, please continue, Ajit.
No, you continue, yeah. So the thing is that when a patient comes with a shock, obviously sometimes, there is a lot of, even otherwise, there is a lot of physician anxiety. So unless we are able to get a rapid diagnosis test with a high, accuracy, accuracy is the sensitivity, specificity it is highly optimal. You are able to say that this is within that to bedside available rapid diagnosis is going to result with a high accuracy. So this, the over treatment to erring towards the safer side. Obviously we can safer side, I can say that it can have a lot of an impact on antibiotic thing and all, but otherwise the erring towards, towards treating the patient will be done by most of the clinicians. And so we should have a rapid diagnosis bedside thing, easily available, cheaply available, which is available. When that is there, it can still reduce the, these kind of overuse. That'll be my take on that.
And to balance this early treatment with antimicrobial stewardship, the only step that we can suggest is early de-escalation. Because rather than thinking too much about whether to start, not start, even if we start it, what's the harm? If we de-escalate early, I think that will be a good enough job towards antimicrobial stewardship.
I think I might disagree with that statement, Dada. So once a patient gets 3 or more doses of any antibiotic, generally the resistance is already almost nearly expected for that patient. And so vertical resistance is nearly 90%. And so if the patient did get septic again,
you cannot go by numbers because these numbers keep changing.
Yeah, I understand.
So these 3 may become 5.
Early de-escalation doesn't save anything. But
early de-escalation definitely reduces the antibiotic usage. And to preserve antimicrobial stewardship, you have to reduce the overall antibiotic usage, the consumption. If you have a patient who are continuing and ICU for 1 month on his antibiotic usage will definitely be high. That is not a safe practice towards antibiotic stewardship. So early de-escalation, whenever as soon as you are able to diagnose that, yes, this is not sepsis, you stop it.
Maybe we can put some objective criteria to define this possible and probable. Maybe with shock, it is fine, no issues. But without shock, the differentiation between
probably is high suspicion. The possible is basically median, I know this is very subjective, but again, if you are very sure, you have a high suspicion because, then that is probable. Possible is, median suspicion. I know. I understood there is a thing, yeah. Still possible to delineate to some extent. I agree with you.
Yeah, there is a thin line of demarcation between probable and possible sepsis. That's why the question has been framed. Okay, sir. Next is Dr. Anirban. SSC recommends source control within 6 hours. In many Indian hospitals, for patient presenting at night, this may not be possible or feasible due to non-availability of expertise. Could delays more than 6 hours has medical legal implication, and how should hospital organize systems and documentation to address this?
Well, technically, yes, there can be medical legal implications, but medical legal implications, we will have to understand that if we are not able to practice the source control within 6 hours, there should be sufficient reason to believe, which has to be documented, and it should to believe that the best care which is possible in that setting has been taken for any patient. Whenever liability is fixed in a negligence case, it is based upon the average standard care which is possible in that city. If someone has missed that, then only one is liable for negligence, not otherwise. Now, there are a lot of times like, say, non-availability of the OT. One emergency OT is there, already one case is going on. So this septic patient who needs to be drained of his abscess got delayed, or anesthetist not available, surgeon not available, whatever may the reason. But if the general care of the patient has been duly taken, whatever best possible, everything has been documented, and patients have been, the attendance consent have been taken for all measures, there is no reason to believe that there will be too much of concern for medical legal issues. But at the same time, for any medical setup where such a thing can happen, if they have a particular SOP, that let us think that instead of 6 hours, they make it that yes, it is 12 hours. That if any patient comes in the night, within 12 hours, we will target to meet up these A, B, C, X, Y, Z. That is also very much possible, because you have to realize that this is a suggestion. This is a guideline, not a guideline. The evidences for the 6 hours is not adequate, and logistic issues are also there. So it should not be taken that it is a very sacred thread which cannot be pivoted, and there will always a sword hanging in case we move from 6 hours to 6 hours and 10 minutes. That is also not correct.
Sir, can these organizational SOPs can be questioned on the basis of guidelines in court?
No.
No, I don't think so.
Guidelines has given a suggestion. It is not a verdict. It has given a framework. As I said, that guidelines are framework. The bedside is the answer to that framework. So if something is not feasible within that 6 hours at that particular place, in some because of its geographic location, logistic inavailabilities, etc., that 6 hours cannot be, and it will never be in the court of law. I have not seen, I have attended more than 15 or 20 courts as an expert, of course, in negligence. I have never seen court have taken they have taken a very balanced view of what could have been done at that particular point of time. So that 6 hours becomes insignificant in such case.
I would probably add that, we cannot equate the event as if blanket 6 hours. Let's have 4 common examples: necrotizing fasciitis in shock, and endocarditis presenting in shock, osteoarthritis presenting in shock, pyelonephritis presenting in shock. All are in shock, but the time delay between each of them having a source control can go from an hour or 2 for necrotizing fasciitis, where you need to go as soon as possible, to a peritonitis which can be done under 6 hours following adequate resuscitation, to knee getting done within 12 hours, to valve getting done many days later if you're not getting better. So obviously source control, even though all need a surgical repair, can actually be much more variable than just a 6 hours. And obviously that would be the second context other than what Dr. Anirban was saying, which is generally the best available time frame for the resource, just as a time and also the clinical context. Probably both put together will probably make it sometimes go in your favor, sometimes may not go in your favor. Like if you do 12 hours later for a necrotizing fasciitis, that is probably going to be a little bit more problematic. But doing at 12 hours for a
See, that is why I said
aspiration is going to be.
documentation is very important. Once you document, once you know the patient's state requires a source control, and you take every measure that is available to do source control, and yet you are not able to achieve source control because of some logistical issues, that does not make it as a punishable offense and does not make you an accused or a convict for that matter.
So most of the time, what happens is court will appoint experts, and experts believe in guidelines. So will this SOP save us?
No, this SOP will definitely save you. Not 100%, 200% it will save you if there are sufficient reasons to believe that all due care, that is best possible care, which is possible in that setting, was taken for the patient. And court even doesn't want the best. They want the average. Any average center in such a situation would have given what you have given. So in that case, you're off that negligence.
Okay.
We'll move to the next question. Next slide, please. Sir, the guidelines recommend long beta-lactam infusion for sepsis and sepsis, but its adoption in our country remains limited because of the drug stability and logistical challenges. So, how can we bridge this implementation gap? And what practical steps can hospitals take to make prolonged infusion?
So let us look at the evidence, before, if you want to implement this. So basically, almost around 18 RCTs, including one of the landmark trials, I will say it has come in JAMA, that is 2024, that is Blink 3 trial, BLING Blink 3 trial. These studies have shown that there is a tendency for, increased microbiologically cure, and, there is a tendency for little bit of reduction in the mortality when you are using a infusion, prolonged infusion, infusion versus bolus, when you're preferring for an infusion in case of beta-lactams, especially it's quite feasible for, with the short half-lives, like piperacillin, tazobactam, even, the carbapenems. So the thing is that here in this study, they have shown that if you treat around 1,000 patients, you will be able to reduce around 50 mortalities. I will say that maybe, roughly around, one out of 50 patients you treat, one patient you can save. If you treat this with this method, 50 patients you treat, one person's death you can reduce it. So that is significant actually. Around, 50 out of, by 25 out of 1,000, or maybe 1 out of 50, people who are treating, it is going to be, useful. So nowadays, definitely it is believed that the evidence is more for a prolonged infusion. Now the implementation gap in obesity, see, for that we require, obviously we have to give a bolus, then we require, the infusion pumps are, the conventional pumps what you're using, they are exorbitantly expensive, especially the, the imported pumps they are exorbitantly expensive. But I'm very sure sooner or later we will also have our indigenous version will be there. We already have something called Dilaflow. I don't know, my old time when I was working as a junior doctor, that kind of things used to be there, to give the pump by a much cheaper than infusion pumps. You can give it over a period of how many hours you want, 2 hours, 3 hours, 4 hours, you can do that. So I think that is going to be there. But as you said, Anirban, just because the guideline is there, it is not going to, anybody is not going to immediately going to sue us actually. It's a cultural change in the system. And as early as possible, as much as possible, we have to slowly move into that. And then another thing is, when you put a line like this, another concern is that if you want to be really more accurate, then this whatever the line what you're using, it has to be used only for the antibiotic, reduce, the impact of drug interactions, all that sort of thing. We can discuss a lot of, economically, but, what I mean is that, yes, the infusion, it may be Indian Jugadi is going to develop, as I telling all the previous slide also the same thing. It is going to be its own way to do that. But the evidence is maybe, roughly I will say that it will save around, also out of 1,000 patients you treat, 25 patients will be saved. That's a huge number. Maybe 1 out of 50, that's a huge number. So when you practice evidence-based medicine, you need to try to practice and follow as much as possible. That will be my take on this.
So any concerns about the drug stability when you are using prolonged infusion?
Yes, that is one thing that usually it is 3 hours, it will remain stable. So whenever you are using a prolonged infusion for more than 3 hours, you please check that whether your drug remains stable for that period or not. Otherwise, it has benefit. There is no doubt because T over MIC, greater than MIC is the parameter, PKPD parameter for beta-lactam infusion. So theoretically speaking, it is going to cause benefit to the patient without crests and troughs, that fluctuation in the concentration. But as Ajit said, that this benefit needs to be weighed against the other consequences, which will vary from patient to patient.
No, but how the stability in the Indian setting is different from the Western setting? I didn't understand.
No,
Dr.
it is
Kiran?
not different. Who said it is different?
Dr. Kiran is talking about the stability actually.
No,
They'll be the same
stability,
what they're recommending, no? Whatever the studies have
the
shown.
company in its insert mentions that after reconstitution, the solution will remain stable for X period of time. So we
In
need
Indian
to check.
setting, it is not about the drug, but the manpower requirements.
No, that is true. That is true. That is there. I know. I know. But slowly that will also pick up. That is my take on that. Yes, it is promising. But as you said, immediately nobody is going to sue us for this. For these guidelines we are not following. But probably this is the way to go forward. Yes.
Next slide, please.
Justin, it's your turn now. And SSC acknowledges methylene blue, but make no recommendation because of insufficient evidence backed by 6 RCTs and so. And currently, if at all used, it is used as a desperate or salvage therapy. What's your personal view? Does methylene blue have a role in carefully selected patients with refractory vasodilatory septic shock? One question. And how early would you suggest to use it?
So I think Raman is trying to tell me that that I should use it early. There is a subtle clues were being dropped, I believe.
Because
So,
the BP will pick up for sure. So that I need to know that.
Yeah. No, so of all of us, I believe Dr. Muralidhar probably has used the methylene blue the earliest in cardiac surgery. Probably, I think I was probably at the later half when they were trying to use it for when there is a post surgery vasoplegia and they're struggling to come off the pump or something like that, to giving methylene blue. Dr. Muralidhar Kanchi, you probably could probably say a couple of words about methylene blue at that time. No, I think it's bit, so at the end of the day, yeah, sorry, sir, please go ahead. Yeah.
Please continue. I'm listening.
Yeah. So at the end of the day, from a sepsis point of view, like Raman was saying, we all obviously have used it as a rescue. Probably in the last decade and a half, there were times probably pre-COVID, maybe from 15, 16 onwards. Occasionally we started using when we were starting to reach 3 vasopressors, and then we still needed something to give us that boost when we start dialysis or something like that. We started using it as a bridge for us to give us few hours until we could start some therapies and see if there is. And then that obviously never worked. And so, and the end result was that was so at some point we realized that maybe methylene blue, which clearly isn't a vasopressor on its own, but obviously it's a like a catecholamine sparing agent, and probably gives certain amount of squeeze because of that secondary effect. As we realize that if you should probably be using like a catecholamine sparing, in this case, probably the second catecholamine rather than so we starting to use it before the third agent, which is after norepinephrine, and then like VAS study, early vasopressin, and then methylene blue. And this practice has probably started going on for quite some time. And then again, that hasn't really changed anything. Like, we couldn't find any bigger benefit with it, and that's probably where the last ones. And so now what we are trying to do is that maybe even before you get to the refractory shock, that means double-digit norepinephrine infusion in your general practice as a thumb rule, whether you would want to give it at that time so that you could even like lower the norepinephrine dose that you're doing and probably use the vasopressin along with it that may allow you to have a different vasoactive medicine so that your catecholamine dose is or exposure to it is so low that whatever side effects that you would get, like how Willy is for ventilator, we are trying to do catecholamine preventing strategies or non-catecholamine strategies and see if that would help with these vasodilatory shocks. And obviously, this is unproven at this point of time as a hypothetical concept, like when I'm seeing the research and thinking about when to use. And that's why guidelines have decided that we wouldn't want to use it. And I still use it, like, like currently, like I said, my use is somewhere between that, like, between refractory shock and you starting norepinephrine.
No,
And then
we all
suddenly
use it. We all use it, Justin. But maybe
I'm
you are right that we use
particularly,
it a bit late.
yeah.
But see, 10 years back, even used to use steroids late. But now, whenever for shock reversal, whenever a patient is on double inotrope, we are using steroid in septic shock. So similarly, the time may come when people will start using methylene blue also early before waiting for double or triple inotropes and probably.
Obviously, you're right. Probably that's why I think essentially all of these interventions are becoming the like, I know now it's failed trials of time, like metabolic resuscitation, thiamine, vitamin C, and steroids, and all these things are derived essentially. Maybe to some extent, we're trying to get benefit out of non-catecholamine strategy, if I think about it. I don't know whether you think about it that way. If that's the case, then just like ventilator-induced lung injury, the amount of ventilator damage, in this case, catecholamine damage, must be the one that's going to provide us with the sort of some amount of benefit, whether it is a duration to vasopressor relief or like a mortality benefit if there is anything. But at the end of the day, the severity of illness underlying whatever the problem is, and then the sepsis cascade probably is going to take the life, not just a vasoplegia. So it's going to be very difficult to prove a mortality benefit just because we moved that into a different category, and then maybe we have reduced the dose of catecholamine. I'm not sure we are yet there to completely remove catecholamines. Like our all guidelines for every shock is norepinephrine start first. And we just spoken earlier in this meeting that you start norepinephrine even before the second bolus. So obviously, we are going to be exposed to certain amount of norepinephrine. So that's where, so most of at this point of time, we are still using as a rescue when the doses are quite steeply escalating and you are starting some other intervention like an extracorporeal therapy, RRT or something like that. You use it as a bridge and a little bit earlier than in the olden days where we used to be as a, like, as after 3 agents. Now we are just at one and a half agent we are using it.
Muralidhar sir, does he have any experience with the cardiac? He will be using for the cardiac surgery, right? Maybe if you can give any opinion about that. Is he there?
So
are you mentioning me?
Yeah, yes.
Yeah. See, methylene blue is a very useful agent. Actually, as pointed out, it's a rescue therapy for patients with refractory septic shock experiencing profound vasodilatation. When you have exhausted the fluids and vasopressors, and it acts by reducing the nitric oxide synthesis and provides benefit to these patients. And in cardiac surgery, especially, it is very valuable in patients who are on ACE inhibitors before surgery, and those who have congestive failure and NYHA class 4. These patients exhibit profound vasodilatation at the end of the surgery, and in these patients, it definitely has a role, and it may actually salvage the situation by improving the vascular tone and improving the mean arterial pressure. That's my take on this. Thank you.
Very good. Next slide. Next slide, please.
Next question, I think.
Yeah. So again, the guidelines now currently mention HFNC as the preferred respiratory support for sepsis-associated hypoxemic respiratory failure or NAV, and even they recommend that we can use intermittently HFNC, alternating HFNC and NAV, even though the evidence is low. So how can we accept that in the Indian scenario? Because we know post-COVID, almost all the institutions have adequate number of HFNC machines, but considering the oxygen consumption, so how should we prioritize some category of patients who definitely will benefit from HFNC comparing the cost and consumption?
Again, like other aspects like water, other catecholamines or whatever that may be there, or ventilator, where we are trying to get away as low as possible. Here again, the whole idea is that NIV, unless you are in one of those Italian ICUs, everywhere else will result in indiscriminate use of inappropriate volumes and pressure. And that's where essentially it's a harm prevention strategy for HFNC. I think when Florali came, and this is probably rather than HFNC being superior, it's the NIV being inferior, probably as a strategy. I think Raman, if hopefully you agree with that statement. Yeah. So that's probably what we feel is that the HFNC use has become predominantly harm prevention, whilst become a what we call the advanced oxygen delivery device with rather than a fixed, but it's a lot more dynamic oxygen delivery device. And maybe if you are using at the highest settings, may even be able to provide positive pressure in ideal settings. And so that's probably where we are looking to see if we could probably suggest that HFNC probably trumps other modes at this point of time, where the harm of the positive pressure and high tidal volume is limited.
No, I think the question was asked because of the oxygen consumption and the cost involved.
Post COVID, obviously, most of us probably have been able to think through, like some of the hospitals that I now work in Bangalore have got their own liquid oxygen setups, and probably the supply chains have been a lot more robust now. So, and they are able to do it, and at this point of time, luckily, the patients, particularly wherever the private setups are there, the oxygen charges seem to be the same for the day, whether you are getting 2 liters oxygen or 30 liters per minute through HFNC. So in that sense, as long as you're in the oxygen or not is the only thing that seems to be the difference. So cost-wise, probably won't say, but consumption and the resource utilization and the green ICU project, maybe that's probably where these decisions could be made. But would that really mean that would you put them on an NIV and provide them with marginally higher risk of harm? Probably not. And I think the balance would be that we would tolerate the oxygen consumption as long as the cost isn't going to be changing just because they are on HFNC.
So next slide, please.
So yeah, that's the thing. So that's what I also believe that personally, HFNC versus NAV, I don't know there is a significant difference. I'm just coming to that. Maybe the HFNC, maybe the patient may be more comfortable, a little bit of, just Dr. Justin is telling some kind of an nasopharyngeal PEEP may be there. But otherwise, the thing is that patients, I would prefer to use, NIV on patients with pulmonary edema and patients who's having an underlying obstructive airway disease, or there is a, vocal breathing is more. But otherwise, I don't think it's a strong indication based on the current evidence that you need to switch to HFNC. Obviously, because it's more luxurious, when patient is more comfortable, patient can eat comfortably, there is no claustrophobia, all that sort of things are there. But I think it is too early to say that no, you recommend as the first choice over NIV at this point of time.
No, but Ajit, if the
No.
patient is because of sepsis with acute hypoxemic respiratory failure,
Hmm.
I think with NIV, there is always a chance of ventilator-induced lung injury because you cannot give lung protective ventilation.
I agree. I know.
Always you tend to exceed 6 mils per kg because you overshoot that. So if you want to,
But sepsis, we will not give. We will not give them NIV also, isn't it? In a sepsis
no, this is
condition.
associated with ARDS, acute hypoxemic respiratory.
Okay, you mean to say ARDS? Okay.
Yeah,
sorry. Okay,
sepsis
okay.
associated with ARDS.
ARDS. Okay.
At the end of the day, non-cardiogenic pulmonary edema, that's what he meant.
So self-inflicted lung injury. Okay, that's fine. I think it's an academic possibility. I know. I'm not denying that, but at this point of time, it is very. COVID has shown that it doesn't make much of a difference. Yes, I agree with you. There is a concern. Is a self-inflicted
Otherwise, there
lung
is no
injury.
difference in outcome as such.
Outcomes, yeah.
Neither is superior over the other.
So in that context, I want to add one more thing. See, during the COVID time, when patient is having a bilateral pneumonia, ARDS, whatever the so-called ARDS, everybody had technically. So people used to do pranayama. To me, that is extremely harmful. So when you take a deep breath, you are going to increase the lung volume, whatever. You are going to harm actually. And people will say that when your lung is injured, the harm is going to be more. So I strongly believe it should have been banned actually that particular time. But unfortunately, in our country, it has been promoted, without any second thought. Yes, technically it is true. HFNC may be better to avoid self-inflicted lung injury, but I think for implementation all spheres, I think it's going to be really challenging at this point of time.
Okay, thank you. Next slide.
Next slide is Dr. Anirban. SSC recommends structured post-ICU follow-up for survivors as well as their family. Since you have successfully established post-ICU clinic in the public sector, what are the biggest challenges you faced and what are the practical advice would you give to the centers who's planning to start one? Is there any standardized checklist which will suit our culture? Is available in India or not?
So no such checklist is available. We will have to create for ourselves. And we have started post-ICU clinic in Safdarjung Hospital, and that is online. So the government of India has a site, www.esanjeevani.com. So in that site, if you log on and you choose, you will find the critical care medicine option. And in that critical care medicine option, you can choose Safdarjung Hospital. And when you choose, you can see my name. So that operates for twice a week from 10 a.m. So we are getting lukewarm response. I'm not saying that it was excellent, it is flooded, but yes, within a small period of 1.5 to 2 hours, it is not possible to see the patients. But there are some challenges involved because initially I wanted to start a normal ICU clinic. But as you know, post-ICU clinic for administrative reasons, it is not a priority for the hospital or the institute, number one. And acute care is more a priority in the ICU beds. But post ICU follow up, yes, people understand its value, understand its importance. But for a hospital perspective, it is not. It doesn't assume that priority in a public sector hospital. Number two is that there is often a mixed sharing of responsibilities. Like some people may say that already the patient can come for follow-up for the surgery OPD or to the medicine OPD or to the pulmonary OPD for the primary disease. So patient is coming, if required, anything else can be provided, patient will get referred to you. So nobody sees that then there's a primary patient belongs to the critical care medicine and it should be followed in the critical care medicine. So that is also not there. So, and thirdly, of course, is the logistical reasons, because in our hospital, patients come from as far as Jammu and Kashmir to Bihar, Orissa, Madhya Pradesh. For them, physically coming is difficult. So this online system is a better option in which they can log in easily. But again, in online system, also there are some problems because you have to write your complaints. Only when you write your complaints, you can move on to the next page. In next page, you give some more information. Then the site scrolls over and goes to the next page. So like that, people have to do a little bit of exercise of typing, running, etc. And all of the population, the village the villagers may not be so much of adapted or used to such typing exercise. They need help from others. So that may be a challenge. I will point it out to the National Health Authority of India in the next meeting so that it can be waived off. And there are also other logistic challenges because in the midst of the connectivity issues are there, particularly for the patients who are connecting from remote villages, for their internet connectivity issues. Everyone, you don't have the same the bandwidth or the of connectivity. So that is there. So if we want to practice ICU clinic, I think we should have to focus on some basic minimum things like what some scores to fix that, whether patient is, how good is it about is very having any symptoms of this psychiatric symptoms, is he able to breathing, what is the activities of daily living. If we can select 4 or 5 questions or of which are equivocally similar for most categories of the patient, that would be the best possible way to start a post ICU clinic, and so that we are able to determine that which patients would require a physical follow-up visit and where even a online consultation can be sufficient. So we are running this program. It has been 2, 3, 4 months. So we are gaining experience. We are understanding the pulse and understanding the modus operandi. So when we practice a bit more, we will be able to further understand the nuances.
Sir, how do you follow up the cases? Are all the cases in the ICU or you classify
No,
as per the length of stay?
no. We give in the discharge, we mention it to the patients that you log on Tuesdays and Thursdays between wherever you are, you log on to www. And there they require that Abha ID, Ayushman Bharat ID. But these things are simple. Now, Government of India's all those the things, these are self-explanatory. It is not that difficult. With average education level also, if they don't have Abha ID, it gets generated once they type their Aadhaar number. So, of course, with those OTPs and all. So once that Abha ID is there and once they are enrolled, and so automatically the memory is remained. So with the same login ID, with the same IP address, they don't have any problems. That's what I can see. And we give it to all the patients, but not all patients report back. Maybe only as what I can see, little more than say 10 to 15% of the patients only log in, and only 5 to 10% of the patients maintain continuity.
Sir, I need a clarification on how do you choose these patients? And suppose one patient gets admitted for 2 days, will you follow up that case or you go with the patients which will be in the ICU for more than
Now,
6 days or 7 days?
whenever we discharge our patients from the ICU to the ward, we mention it in the discharge paper. And when the patient is finally discharged by the respective ward to home, they also mention it in their discharge paper, whatever we have written. And we also explain it to the patient. And some patients are curious and inquisitive. So after 2 days only, they try login. And once they find, some of them continue for some time, some of them get bored and stop logging. So all things are there.
Sir, do you recommend telephonic interview rather than going online?
Yeah, telephonic interview is also even in online. If you get a video conferencing, which we do, where that is good enough in video patients because someone is there. But the only thing is that to reach up to that video level, first patients have to type the complaints, because eSanjeevani.com is not a portal for ICU only. It involves a lot of other medicine, surgery, lot of other. So, and gradually the system itself will taper down the list of options and take you to so after you join, you get a video conferencing. So video conferencing is good enough.
Okay.
Okay. Next slide, please. Next slide. So, Dr. Ajit, I think for quite some time we have been searching for the ideal biomarker, the troponin of sepsis, which we can use to diagnose the disease. But till now, we haven't found one. So, could AI succeed where biomarkers have failed? And will the future of sepsis diagnosis rely less on a single test and more on AI integrating the vital signs, lab data, imaging, and electronic health records? What's your take on that, sir?
So AI, artificial intelligence can imbibe a lot of data, from the structured data, the the health records, the lab data, and unstructured data, the physician notes and all that sort of thing. It can have supervised and unsupervised learning. Supervised learning means you give the input and the output to the AI. It will find out the relation between the input and the outcome, whatever you call outcome. It'll find out. It will make a statistical correlation between the input and the output, and they'll give you. Unstructured, unsupervised learning is that it is not given it is just giving the input. Then it will just try to have the pattern recognition among the thing and try to do that. Studies have shown that, in fact, the early studies have shown that AI has, in fact, surpassed even, the so-called, the mu score and, the new score. That's what I can't exactly quote where it is, but studies have shown that it is definitely superior to SOFA, even Apache and all in predicting mortality. There is no doubt about that. That is one thing. Regarding the sepsis is concerned, there are some landmark stuff is there in AI. There is one is called TREWS, TREWS. I think it's a target real-time early warning system, TREWS. Basically, there by John Hopkins University. This has been known to flag sepsis maybe 6 to 12 hours before. It can predict sepsis. Another thing is Sepsis Watch. I think interested students can just watch Sepsis Watch. Basically, it has been known to reduce the mortality in sepsis. I don't want to make any overclaim because obviously AI is still evolving day by day, hour by hour. It is going to change. But the Sepsis Watch has shown that it can decrease the mortality. Obviously, we can discuss a lot about those kind of things. And when other things, combos or some kind of things are there. These are the things which has been useful in sepsis. It can predict sepsis. Even much earlier, maybe 6 to 12 hours earlier as well. So AI is one way to go because initially some of the studies have shown that AI can surpass the usual whatever the scoring systems. So biomarkers, I can't talk about it on based on evidence-based medicine, but AI is going to be integrated in sepsis management directly, indirectly, and it is going to be there in ICU, even directly, indirectly in the future. There is no doubt about that.
Yeah. Yes, I can see a lot of startups and technological firms, IT firms now coming up with softwares and AI-enabled softwares to detect sepsis and all. So maybe in future,
yes,
near future, maybe we'll have
TREWS is supposed to be very promising. TREWS and in the Sepsis Watch. Yes,
Okay.
Sepsis Watch is claimed to reduce the mortality. Again, at this point in time, everything we have to read with a pinch of salt. I agree.
Okay, thank you. Next slide, please.
Dr. Justin, all these novel things are coming to you. Blood purification therapies remain attractive, but the people are using it, but lack of clear survival benefit as per SSC. Moreover, it is not equitable, as you know. In India, should we continue using them as rescue therapies or prioritize resources for better prevent sepsis intervention? What's your take on this?
I think it's going to be really difficult and justify ourselves for using blood purification strategies if anybody is using already as before. So probably in the last 5 years of blood purification adsorption strategies that I've used has always been probably for particularly in sepsis, tropical sepsis with the high inflammatory presentation and within the first 24 hours. I've picked and chosen that subcategory based on my reading at that time. And then obviously these are very small set of patients, some on necrotizing fasciitis or dengue shock syndrome, things like that. So, and one had this typhoid. Obviously, culture came further later. It all looked like tropical sepsis, but salmonella sepsis in a hyperinflammatory state. So, all of these patients, within the first 12 hours of presentation to the ICU that they all got these filters, particularly when the hyperinflammatory phase is there. And the understanding, physiological understanding at that time, or even for me now, is that they still don't have that CARS element started, and that we are only removing the hyperinflammatory interleukins and other things, not the so-called anti-inflammatory agents. And so that's the rationale that I had used, and probably whether that was really beneficial or not, quite a lot of people did well with that strategy, but it has never informed me to use blanketly for everybody. And I always used it as a measure, as an adjuvant to most of other therapies, like, and there's a prioritize the other resources like we were doing. And then, so like how I'm using methylene blue, and Dr. Anirban was saying that we're all using it. And even though it doesn't have mortality benefit or major difference, we are using it probably more and more earlier because we felt like we are starting to understand its place. I've realized that the methylene blue has a, the adrenaline and probably some noradrenaline catecholamine sparing effect. Similarly, whether I'm using this where pure steroid wasn't sufficient as an immunomodulator, there may be places. And in those cases, probably to take that edge off, maybe that's the other possible explanation. But moving forward, once I think there was a big narrative review and meta-analysis last week that came through, and SEC guidelines, all of them put together probably makes it even that justifiably difficult moving forward, I think.
I think more importantly is that the blood purification therapies, even whether it is cytosorb or oxidase or our polymyxin B, what is that called? The Euphrates trial used it. The Japanese one, toremixin.
Toremixin, yes.
So whether it is, the point is that unlike methylene blue, unlike steroids, they don't say that it harm. But these purification therapies in the studies, they have always found to cause more harm. And their use only has been in the Indian continent, in the Indian subcontinent, maximum in the Indian, maybe a little bit in Japanese, China, South Asia, etc. In the Europe, US, there has been restricted, and whenever their well-designed trials they have tried, they have been found to cause harm. Not only that, no benefit, no difference, not even that. They have. So I think, although I have also used it and I have reduced my usage because earlier I used to think that, well, CRRT patient is already on, put one more cartridge extra and check it, the cytokines will be removed. But how much cytokines or interleukins are actually being washed? And even if they're being removed, if the organ dysfunction has already set in, how much difference it is making to a organ dysfunction? I think we don't have these answers. So they are no longer attractive as they used to be 5-7 years back.
Yeah. So having said that, the toremixin has been recently approved in US, maybe around 2-3 months ago. It has been approved in US, and they proved that it is because of the so-called the Bayesian approach, posterior approach, whatever we call it. I'm not a great in statistical thing. The posterior possibilities, whatever we call it, the posterior probabilities. So it has been approved there by the Bayesian approach, not by the frequentist approach what we are using in current statistics. It has been approved just 3 months ago, yes.
Sir, how could we justify ourselves, that is considering the cost of this, and we are not waiting for the 12, it has to be initiated within 12 to 24 hours, antibiotics had to act and culture had to come. Then how could we justify ourselves initiating this as early as possible within 12 to 24 hours?
I don't think one can justify its use within 12 to 24 hours after exhausting all other options, because all other options that you need to exhaust before using them, we have to call it as a rescue therapy when nothing is working. Now, to say nothing is working and you are starting it within 12 to 4 hours, that means we have not adequately tested that whether the rest of the things are working or not, or you have been too impatient in waiting or checking the patient's response. Okay. So it is something like that.
I'll generally my explanation is that it's a mix of infection and inflammation. Most of our ICU patients, particularly, and then I give the example of COVID. Same family, 4 members of the family got the same Delta virus, but one is no symptoms, one is accidentally positive, one is having continuous fever, one is admitted to hospital with oxygen. Obviously, that tells you that infection has some component and the inflammation has a significant component.
No,
The
but
more
in
the
this case,
inflammation,
when we are talking about purification therapies, we are meaning shock patients. So
and
these
hence, so
patients have
at the end of the day, most of the antimicrobial therapies and the strategies for source control generally address the infection. But once the sepsis cascade starts, the current strategy that we have is that as an immunomodulation, only steroid and protein C and all the other things that we have done APCs have
we
gone
know
away
that
now.
immune hyperimmune, then
Hyperimmune. So
immune paralysis and all these things. But these are all we know
in
that these
terms
are all
of
mere
the
forms
in
of
terms of
intellectual
the
gymnastics rather
in
than
terms of
foolproof.
yeah. In terms of SARS spike, the higher the spike, whether that top half, whether the removal rather than modulation was going to be beneficial was my hypothesis in way of like trying to explain the concept to how I used it in the past. But if it is not, and probably I will sparingly use in future should I feel like that's probably where we might be coming up with some other biomarker strategies like using IL-6, ferritin, and CRPs and all, or procalcitonin, all put together as a biomarker to differentiate how much of it is infection, how much of
People have tried endotoxin level, EA, endotoxin SA
That's
levels,
what
and
endotoxin represents infection. What we are looking at is that like how hyperinflammatory response. Like recently, there was a paper about hyper and hypoinflammatory
there
where
has been,
they
I
have
think the study after which Ajit suggested that had presepsin also as one of the components. So I think that on this ground, industries have used all their might to prove that this treatment strategy is beneficial. They have spent enough, they have tried their best means, but they have tried to do all possible jugglery with the statistics, but still they have not come out. More and more they have tried. I think more and more it have been expressed that it can cause more harm than good in the studies. So in practice, everyone will have a different experience, but I think it will be only a utopian to think that this will come as a guideline anytime in the near future also.
Okay. So that was the 12 questions, and now we are coming to the concluding part of our today's panel discussion. We have 3 questions for open discussion. So the first one is, many recommendations in the current guideline are built on previous versions rather than some introducing radical changes. And from your perspective, has this guideline genuinely changed your day-to-day clinical practice? Anybody is free to answer.
I think from my practice point of view, it has not genuinely changed, although my concern has been lifted or raised about the time, the pre-hospital and those counseling and the prospective idea of being able to use the AI-driven tools for prognostication, etc. That have raised my inquisitiveness, that have given a direction to my thought. But I think at the end of the day, we are using the same processes of resuscitation, maintenance, antibiotics, steroids, and our approach to any septic patient has not changed on the basis of the 2026 guidelines.
Any difference of opinion from others? Or everybody agrees with that? Ajit sir? Okay. Okay, then the second question. Again, the guidelines are updated every 4 to 5 years. But in the interim, newer and newer evidences emerge in between. So is it time to move to a living guideline model rather than waiting for the 4 to 5 years for a major revision? Because we might be already practicing the updates. So that may be the reason why when the guidelines come.
It is absolutely pragmatic to wait for a sufficient time. I'm not going to stick that it is whether it should be 3 or 4 or 5, but yes, it should be wait for to see the balance, because whenever in the waves there is undulation, and after a time the water becomes still, and only when the water becomes still you are able to see if the water is clean. You are able to see the bottom from the surface. So if there is some importance evidence is emerging, say within 6 months, we need to give that minimum of time for it to substantiate, for it to stabilize, so that we can see that change, the effect of that change more clearly, rather than trying to change our guidelines and follow a practice changing guidelines prematurely.
I probably think it should be longer based on the available evidence.
Yeah, evidence always lags behind, the launch.
No. It's not about the evidence proves that you changed ventilator strategies like low tidal volume. It has taken 10 to 12 years for
yes
80+% of the people to adapt to it.
That's
Sepsis guidelines, when it was initiated, even today, it has not reached 80% compliance.
Yeah.
The 2014 sepsis guidelines, after 12 years, we have not reached 80% compliance yet.
Yeah. So that's it. See, even approaches actually. So when you say an approach which is useful, for example, prolonged infusion. So people have been using that. But when we talk about that, when it's come to evidence, it took some many more years, long years. And obviously, I agree with your compliance thing. I understood that.
Not only that, you see, for guidelines, you need good studies to come.
Yes.
You need systematic reviews. These systematic reviews will also include studies, whether they're observational, interventional, whatever. Now, for those systematic reviews, all waiting for the studies to be conducted. After those studies are conducted, reviews are conducted, then only the guidelines will take. Otherwise, it is just 3 new articles have surfaced. And if we do another guidelines based upon 25 plus 3, that won't be much different from the guidelines which was based on 25, because those 3 is not going to make a huge difference to the data set that already exists. So some time should be given, at least to it become stabilized, to understand, and then refine things more realistically, rather than as a knee-jerk reaction.
Okay. So next, So the final question: should we consider developing our own sepsis guidelines rather than adapting the international guidelines? Incorporating our microbial etiologies, antimicrobial resistance patterns, and our logistical issues and economic realities.
We can do that, but then again, after 10 years, there can be separate Bangalore sepsis guidelines, Trivandrum sepsis guidelines, Delhi sepsis guidelines, East Delhi sepsis, because there is no end to subdivision, like do subgroup analysis. But once if we can make a good guidelines having representation from all data sets, then we get sufficient information from that the guidelines, which is applicable in wide variety of the situation. For example, if we don't get good results in a study or the expected result in a study, we try to do some post hoc analysis, we try to do subgroup analysis, somehow we want to decipher something something, if we are able to find out, it will get published. Now the same, if we follow in the guidelines and try to change things, it is not going to give us anything extra.
The thing is, out of 69 panelists, only less than 30% is from low and middle income group. So we don't have any representation over there.
But the Indian data is represented in the guidelines, no?
A little bit.
Yeah.
Since 2016, I think 2016, 2021, 2026, all these years, Indian institutes' data have been compiled and this has been integrated. So
But the most of the data coming from the higher income countries. So naturally, that could be one.
See, guidelines give you a framework. They don't tell you that you just do it, as I say. These are on the basis of which you can decide your own guidelines in your setup, in your hospital, in your ICU, whatever it may be. So for that, why do you need a framework which has to be made in India or something like that? You can use the framework which is available worldwide and also change things that are necessary at your end if there are reasons, if you find enough reasons for that. I think that should not be a problem, whether it is a guideline Indian centric or world centric.
There was one question in the chat box. We will answer that also before finishing. That is, from your experience, what are the 3 most common mistakes made by the postgraduate residents in the early recognition and management of sepsis, and how to prevent these errors?
I could not follow your question. Can you?
No, the question was
from your experience. I can read. What are the 3 most common mistakes made by postgraduate residents in the early recognition and management of sepsis, and how the 2026 guidelines prevent this error? See, 2026 guidelines are there to facilitate, to help you improve your understanding. They cannot actually prevent your misdiagnosis. So misses are common. Misses are common not only among the residents, misses are common among many seniors also. If the cardinal symptoms with which we usually associated sepsis, like high-grade fever, tachycardia, etc., are absent. So people tend to think that, so we have to know that cold sepsis is a very important element where you won't get fever, you may get some amount of hypotension, hemodynamic instability, which may be the only reasons. The counts may not be very high, etc. So these patients will also have sepsis. Many postgraduates will feel that otherwise a hemodynamically stable patient with worsening orientation, worsening mentation is actually going into sepsis, is something also which students tend to miss, at least in their initial days of residency. Thirdly, if we are not able to wean the patients from the ventilator and the patient is not having any increase in counts, the patient is not having any fever or such escalating the inotropes, but patient is not being able to wean from the ventilator, and you see that the patients is on antibiotics. So these are the patients who are developing some kind of new infections or ventilator-associated pneumonia or fungal infections. So these are some of the common things which the first-year postgraduates trainees tend to miss at times. There may be many more, but these are the common ones which we see in my experience.
So basically, I have a kind of a conflict of interest in that. So I believe that any patient with any unexpected hypotension, shock and all, if you want to say septic shock, you had all that definition, but any hypotension, I strongly believe the patient has to come to the ICU. One common mistake people do is that patient's BP is on the lower side, they'll give some fluid, and BP will pick up. It was around 80 by 50 was there. You give some fluid, it make 100 there, you send the patient to the ward from the emergency or somewhere, or you keep the patient in the ward. So what's happening is that there is no monitoring which is going to happen. After 1 hour again, sepsis is not going to keep quiet. It is going to fall again. So by the time it is too late, actually, other organ failure will set in, hypotension, AT, and other organs are affected. So any patient with a shock has to be monitored in an ICU setting is my thing. That's a very common mistake, which is postgraduate students, make actually, because and early acute shock is very, very important. Shock is a dire medical emergency, whether any kind of shock is a dire emergency, it is going to multi-organ failure. So identification is very, very important. One episode of hypotension, it has to be ideally monitored in an ICU setting, because once, even if with a fluid bolus it is going to improve, it is again going to fall after some time and you're going to lose patients. Finally, the patient may crash in the ward. So identification shock is extremely important. That's what my message. And obviously, early antibiotic administration is extremely important. The more delay is there, the more mortality is going to happen. That is the second point. And I think that's the only valid point I have. Rest of things are very, we are already exhaustively discussed. Yeah.
So I think we have come to the conclusion of today's webinar. So I will just brief the take-home points we have discussed, and then we will wind up. So regarding the 2026 guidelines, yes, the pre-hospital management of sepsis, we are still far away, but we may not be possible to implement that in soon. But we can have core sepsis in the hospital where a multidisciplinary approach and early initiation of diagnosis and treatment can be initiated. And in the ER, the NEWS2 score, scoring system can be used to early detect and diagnose sepsis. And again, early vasopressors along with the fluids, still we will go with that. And regarding the definition of probable and possible sepsis, yes, there can be subjective differences, and the need for an objective criteria is needed. But for the time being, then if you suspect sepsis, then you will go with the antibiotics, and considering the antimicrobial resistance, we will go with the early de-escalation. And we will have the institutional SOPs regarding it would be better to have the institutional SOPs regarding the source control if it is not possible in 6 hours. Ideal to have a source control within 6 hours, but even if it is not possible, then better to have an institutional SOP and have the source control at the earliest. And regarding the antibiotic infusion, prolonged infusion, definitely we will have to give, and we will have to go with the prolonged infusion considering the evidence. And regarding methylene blue, even though the guidelines doesn't make a clear stand, when your vasopressor requirements are high, when you have started the first vasopressor, second vasopressor, then maybe it is the time when you can try methylene blue instead of waiting till the last stage. And regarding HFNC and NAV, yes, for any hypoxemic respiratory failure associated with the sepsis, maybe patient will be more comfortable with HFNC. So we'll have to consider the patient improvement rather than patient improvement on HFNC rather than the lung damage inflicted due to the overventilation inflicted by NIV over the cost considerations. And post-ICU follow-up is necessary. And regarding the AI in sepsis, the Sepsis Watch and TRUS, these are the two of the many AI technologies which helps to or decreases the mortality in sepsis. And regarding the extracorporeal therapies, currently there is no role for extracorporeal therapies in sepsis. So that's the key takeaway points. Thank you all. Rahul?
Thank you very much,
Thank
Kiran.
you.
Thank you, Dr. Raman.
Yes,
Thank you, Ajit, Justin, Dr. Rajaji. If you are there, Rajaji must be in the flight by now.
Yes.
And
I think he left.
and the entire team of Alnios.
Just he left, sir.
Yeah, and also thank
So-
all the participants who were patiently listening to this discussion.
Yes, sir.
Over to Rahul.
So,
Okay,
respected
sir,
chairperson.
sir,
Yeah,
good
yeah.
night.
Yeah, sir, Murli, sir. Yeah.
Good night. Good night. Rahul, you can conclude to the
Yeah, sir.
to the participants regarding this change of modus of operandi, because exam seasons are over and we will be focusing on lectures after one more, and the 26th will be the exam setting. And after that, more of lectures will be coming, and in the season of exam, we'll switch to the exam setting. That's our plan is.
Yes, thank you. So, respected chairperson, esteemed faculty, and distinguished moderators, dear doctors, ladies and gentlemen, good evening. As we came to the end of this enriching academic session, it is my great privilege to propose the vote of thanks on behalf of Ineos Pharma and the Impact PG team. Today's program, the India Lens Decoding the 2026 Surviving Sepsis Guidelines, has been an outstanding academic experience, providing us the valuable insights into the latest evidence and its practical application to the Indian critical care setting. We extend our heartfelt gratitude to our eminent faculty members, Dr. Sunil Karand, Dr. Anirban Home Chowdhury, Dr. Ajit Kumar AK, and Dr. Justin A. Gobaldas for sharing their vast knowledge, clinical expertise, and practical perspectives. Your thought-provoking presentations and evidence-based discussions have greatly enriched our understanding of the updated surviving sepsis guidelines. Our sincere thanks go to our esteemed moderators, Dr. Raman Muralidharan and Dr. Kiran Rajagopal, for seamlessly guiding today's discussion and making the session interactive, engaging, and highly informative. A very special note of gratitude to Dr. Jacob George for his visionary leadership, constant encouragement, and unwavering support in making this academic initiative grand success. Your commitment to advancing medical education continues to inspire all of us. Today is also a landmark occasion for all of us, as this marks the first ever Physical Impact PG program. It is truly proud milestone, and we are delighted to have brought together such an esteemed panel of experts and passionate healthcare professionals under one roof. We sincerely hope this is the beginning of many more impactful academic engagement sessions in the future. We also extend our heartfelt appreciation to every doctor and healthcare professional who joined us today. Your enthusiastic participation, insightful questions, and dedication to the continuous learning are what make programs like this truly meaningful. And sincere thank to the entire organizing committee, the Impact PG team, every member of iNews Pharma who work hard, meticulously planning and dedication ensured the seamless execution of this event. We conclude, let us carry forward the knowledge gained today into your clinical practice and continue striving towards better patient outcomes. Once again, thank you to all our speaker, moderators, participants, and everyone who have contributed to the success of this memorable event. Have a wonderful evening, safe travel, and we look forward to meet you again in our upcoming academic session. And as Murli sir told, the sessions was held by Ronaldo, Messi, Neymar, and even everyone. So all has won the World Cup.
Okay.
Okay.
Thank you, Rahul.
So
Thank
thank
you
you,
all.
sir. Thank you once again.
Thank you, Rahul. Thank you. Thank you, Kiran. Thank you, Kiran.
Thank you, sir. Thank you, sir. Thank you, everybody. Good night.
Thank you.
sir.
Good night. Good night.
Bye. Thank you.